Okay, folks, welcome, and my apologies for not being available today. Today's lesson is going to cover the respiratory system, which is one of the most vital systems of your body. So let's go over some of the major functions of the respiratory system. Well, what is it meant to do? Primarily, it's meant to exchange oxygen from the atmosphere for carbon dioxide and waste. Oxygen comes into the body, carbon dioxide, which is a waste product of metabolism, leaves the body. Another secondary function of the respiratory system is that it helps maintain the acid-base balance in the body. I think we talked a little bit about the importance of acids and bases in the bloodstream. If the blood becomes too acidic for whatever reason, one of the ways that the body can bring that back to normal is by breathing faster and deeper by blowing off more carbon dioxide. Blowing off more carbon dioxide brings the pH level of the blood back up to its normal level. This slide is a picture of a polar bear stuck in the middle of an Arctic storm. Obviously forgot to delete that. So this is your respiratory system. It's composed of many different organs and organelles, and we're going to go over the anatomy and the physiology and some very important terms. So respirations or breathing actually starts in an area of the brain called the respiratory center. The respiratory centers are located in the part of the brain called the brain stem. If you remember from neurology, there are three major portions of the brain. There's the cerebrum, which is the highest level of the brain, which is involved in thinking and problem solving and emotional processing. Then there is the cerebellum, which is responsible for balance and fine motor movements. But the most vital part of the brain is located right at the base, and that is called the brain stem, which is divided into the pons and the medulla oblongata. Now, it's not really important that you know all the specific parts of the brain stem that initiates respirations, but it's important that you know that you cannot exist without a brain stem. It is the most vital part of the brain. You can live with a loss of a great deal of cerebrum. You can survive with the loss of function of your cerebellum. You cannot survive without your brainstem. Sometimes I give a little more gory details about how that works, but it's just important to know that the brainstem is vital. So the respiratory system anatomically begins with the passageway from which air enters the body. And the first ports of entry are through the nose and through the mouth. And so when air enters the nose, it circulates through this chamber up here. I don't know if I have a pointer here. It circulates through this chamber right here called the nasopharynx, which is lined with cilia and mucus and is meant to warm the air coming in, to trap and filter dirt particles, and to swirl the air around to help warm it up to body temperature. Down here you have the oropharynx, otherwise known as the mouth, which is a secondary backup for air entry, just in case anything happens to the nasal cavity. And way down in the back of the throat, the two of these chambers converge together in an area called the laryngopharynx. And that's where some complications may wind up occurring. If you take a little further look at the upper airway, you can see that when the nasopharynx and the oropharynx converge into the back of the throat, into the laryngopharynx, then you have two separate tubes splitting up. You have the trachea, which is otherwise known as the windpipe, and the esophagus, which is the food tube. The trachea, or the windpipe, is positioned more anterior in the body, which is kind of interesting because it also makes it a little bit more exposed to anything like outside forces, like trauma. Some of these other terms I don't really care if you know about. The adenoids are part of the lymphoid system. They're structures that house a lot of white blood cells. The soft palate is this very floppy area that helps separate the nasopharynx from the oropharynx. What else do we have? We have the larynx here, which we'll look at a little bit more in detail, which is otherwise known as the voice box. So if you look at the gross anatomy of the pulmonary system, you have these structures that sit in the chest cavity. You have a right lung. What do you mean right lung? This is on the left side. Remember, when we talk about anatomic terminology, right always refers to the patient's right, not your own point of view. And the left lung. And right in the middle of the lung sits the heart. Many people think the heart is situated more to the left of the chest. That's actually not true. And it's compact with all these other structures. The aorta, the superior vena cava, the pulmonary trunk, which is the major artery that brings blood back to the lungs. And this area that the heart sits in between the lungs is called the mediastinum. Let's go a little further here. Now, interestingly enough, the lungs themselves are not equal in their makeup. The right lung has 3 major segments called lobes, 3 lobes. The left lung only has 2 lobes, so it's a little bit smaller than the right lung. And the reason it only has 2 lobes is because it needs a little extra space for that protrusion where the heart sits in the apex of the heart. So that's how that's made. If you put this all together, it's a very complex structure. As air enters through the airway, through the nasopharynx and the oropharynx, the air actually enters through the windpipe. And the windpipe, we said, is known as the trachea. The trachea is a long tube that goes from the throat all the way into the chest cavity and ends right about the top of the sternum area. And it's surrounded by rings of cartilage, which keeps it sturdy and open. Then the trachea splits into the right side and to the left side. And we'll just look at the right side for the moment. The right side trachea now splits into another tube that goes into the lung proper, and that's called a bronchus, or bronchi. Bronchi is plural, bronchus is singular. And then the bronchi, or the bronchus, subdivides and subdivides and subdivides, kind of like the branches of a tree, if you could picture an upside down tree. And about 20 subdivisions, then it turns into little structures called the bronchioles, which subdivide and subdivide and subdivide. And then they ultimately give rise to something called the alveoli, which we'll talk about in a few moments. You can see that the lung is bordered and contained by the rib cage and the muscles between the ribs, which are called the intercostal muscles. And on the bottom side of the thoracic cavity, the lungs are bordered by this big dome-like muscle called the diaphragm, which separates the chest cavity from the abdominal cavity. It's also responsible for the mechanics of breathing. Now, another accessory structure of the respiratory system that tends to be misunderstood are the sinuses. Many people think that the sinuses are just the little inside areas of the nose, which get swollen when you have a cold. But no, the sinuses are actually cavities or open spaces within the skull that help keep the skull a little more lightweight, but they're also lined with mucous membranes that help produce mucus and transport them to the nasal cavity. We mentioned that mucus is important for cleaning out and keeping the airway clean and free of dust and debris. You have 4 sets of sinuses, and for the most part we don't notice them until they become inflamed. When you have a viral or bacterial infections in the sinuses, then they become swollen and very painful. And we mentioned the nasal cavity as well. All right, the nasal cavity is a little complex structure. It has these ridges of bones called the nasal concha, or otherwise called the turbinates. And you can see the position of the sinus cavities on this sagittal view here. So when air enters the nose, it goes into the nasal cavity. It's met by that nasal mucosa, those mucous membranes that have cilia and mucus, which warm and filter the air. And then these ridges, these turbinates, swirl the air around as it passes through the nasal cavity. And that helps give a little more time for the air to be filtered. And those ridges are like fingerprints. No two people have the same pattern of ridges. That's what gives rise to the originality of your voice patterns. Now you can see again in the sagittal view here that you have your tongue, which you cannot swallow, as you may have been told when we talked about seizures, because it's attached at the base of the mouth to this little bone called the hyoid. But again, looking down, as food passes through the pharynx, you want it to go posterior into the esophagus, so it doesn't enter the airway. The trachea is much bigger and solid and more anterior. So what prevents that from happening is this very rigid structure called the epiglottis. The epiglottis is a lid that covers over the glottic opening of the trachea as food is being passed down. The problem when you're talking and eating at the same time, sometimes you may not give a chance for that epiglottis to close up, and food can inadvertently pass through the epiglottis into the trachea, causing to cough, gag, and if the food is large enough, ultimately choke. Okay, so you have a relatively complex structure in the larynx, in the middle of the throat, which starts at the epiglottis, which we already talked about, which is that flap of tissue that helps protect foreign bodies from entering the trachea. And everything is all anchored by this structure here called the hyoid bone, which is the only bone in the body that's not connected to any other bone in the skeletal system. Then if you look at the inside, this is the epiglottis. And you have this rigid structure right here called the thyroid cartilage, which in layman's terms is referred to as the Adam's apple. Then the first big cartilage, which really makes up the trachea, is called the arytenoid cartilage, which houses the vocal cords. And then if you can see here, the trachea, as I said before, is lined by these rings of cartilage, but these cartilage rings don't make a full circle. They're C-shaped. So in the posterior part of the trachea, you have just soft tissue. So that's why, and that soft tissue comes into contact with the esophagus. They are positioned right next to each other. So sometimes when you chew off a large piece of steak and you don't chew it up very well and you swallow it, it may sometimes feel like you're choking, even though that steak is not in your trachea, because it's stuck in your esophagus and it's pushing into the soft tissue area of the trachea, giving you that foreign body sensation. And so as I mentioned before, the whole respiratory bronchial passageway really looks like an upside down tree. So the trunk is right here. This is the trachea, which has about 20 or so rings of cartilage. Then it separates. So the term we use for that is called bifurcation, in an area called the carina, into the left and right main stem bronchus. And then those bronchi subdivide and subdivide and subdivide, just like the bronchioles of a tree. The branches of a tree. This we already mentioned, that there's 3 lobes in the right lung, 2 lobes in the left lung. The lung itself is covered by these membranes called the pleura. There are 2 separate pleura. One is called the visceral pleura, which lines the outside of the lung itself. And then there's the parietal pleura, which lines the chest wall, the ribs, the muscles in between the ribs. And these pleura have a potential space in between lined by fluid, so that when the lungs expand and contract, they're not subject to friction and irritation and pain. Some point you should understand about the differences of an airway in a pediatric versus an adult. Remember, children are not just small adults. They have different anatomies and different physiologies. So one thing to consider is that the pediatric airway has a much larger tongue proportionately to the rest of the mouth, making it easier to be obstructed. The trachea itself sits more anterior towards the front, and the larynx is more superior towards the top of the head. And whereas the most narrow part of the cylindrical airway in the adult occurs at the vocal cords, which you cannot really see here, the narrowest part of the pediatric airway is down by that cricoid cartilage. So let's go over some common pulmonary terms that you should be familiar with. The first term I want to talk about is a term called orthopnea. Orthopnea, the need to sit or stand to breathe comfortably. So sometimes we mentioned when you're lying a patient supine for an examination, they cannot tolerate that position, maybe for an EKG or another procedure, because it makes it difficult for them to breathe. Sometimes people need to sleep upright on a bunch of pillows. Some people have such breathing problems that they have to sleep in a reclining chair. That condition is called orthopnea. A greater than normal level of carbon dioxide in the blood is called hypercapnia. Hypercapnia. Now your body actually triggers its breathing response not to low levels of oxygen, but actually to high levels of carbon dioxide. The oxygen levels in your blood can decrease significantly before you feel any discomfort, but there's a very, very little room for deviation in carbon dioxide levels. If your carbon dioxide levels increase just a little bit, your body's going to compensate by breathing harder and faster and harder and faster. The term inspiration simply means inhaling air. What causes you to inhale or inspire? Well, there are two major muscles involved. One is, we're probably familiar with, is the diaphragm, which is that dome-shaped muscle that separates the chest cavity from the abdominal cavity. And at rest, it's concave, or it's bent upwards. When the body wants to breathe, that diaphragm will straighten out or contract and will help pull the lungs open. In addition to that, you have muscles between each rib called the intercostal muscles. Intercostal muscles. And those muscles lift and separate the ribs to expand the chest cavity, again, to pull those lungs open so they can suck air in from the outside world. And then exhalation, which is the opposite, involves just the natural recoil of everything relaxing and contracting the chest cavity and contracting the lungs and pushing air out of the body. A decongestant is a drug that is used for nasal congestion. You have several on the market. Some of the more common brands are Sudafed. True Sudafed, which has pseudoephedrine, is a behind-the-counter medication, meaning it's not a controlled substance, but you have to show ID in order to get it. What you see here is kind of fake Sudafed. It's a Sudafed you can get on the shelf, but it doesn't have the active ingredient pseudoephedrine. It has a different ingredient that most say is not as effective. The reason why true Sudafed has to be sold behind the counter is because the active ingredient, pseudoephedrine, has been used clandestinely to synthesize methamphetamines or crystal meth. And that's a whole story in itself. Afrin is a very effective immediate nasal congestion. The problem is that most people take it incorrectly. It can give very short, quick-acting burst of decongestant in the nasal cavities, but if you use it for more than 3 or 5 days in a row, you can get what's called a rebound congestion, and you can make the condition even worse. So that's a common thing I see in the office when people are complaining that they've got weeks and weeks of nasal congestion, and they've been taking Afrin every single day and it just doesn't work anymore. Well, they're actually causing their own problem. So just something to take note of. A bronchodilator is a medication that helps open up the bronchioles. Remember those soft, flimsy airways full of smooth muscle? To help a person breathe easier. A very common example of a bronchodilator would be an albuterol inhaler. Some people in the class may have a history of asthma or know somebody who does have a history of asthma, and they carry with them a pump for immediate relief. That's called a rescue inhaler. The medication in it is called albuterol, and it's meant to mimic some activity of the sympathetic nervous system to open up the bronchioles to allow air to get through much easier. So we talked about the major muscles of inhalation being the diaphragm and the intercostal muscles. But if you were to run up and down 4 or 5 flights of stairs several times and then come back to the classroom, you would be engaging many more different muscles than just those two that we spoke of. These are called accessory muscles, and these muscles are engaged when a person is either out of breath or having a difficult time breathing or exercising intensely. And you can see in the picture on the left side, you see how the clavicles are kind of pointed upwards, the muscles of the neck are protruding outwards. So these are the accessory muscles. They're called the scalenes, the sternocleidomastoids, part of the pectoralis. The abdominal muscles are involved when a person has to exhale forcefully. There are certain types of respiratory conditions like chronic obstructive pulmonary disease where a patient doesn't really have so much trouble getting the air in, they have trouble getting the air out. And instead of it being a passive process where it just naturally relaxes, the person actually has to physically push air out of their lungs. And they use the abdominal muscles to do so. So before I talk about surfactant, I should talk about the little organelle involved. I talked about how the trachea divides into the bronchi and then the bronchioles, and then ultimately it ends in these little bubbly sacs of membranes that look like clusters of grapes, and these are where oxygen is exchanged from the airway into the bloodstream. They're surrounded by capillaries, and they're called the alveoli. They're kept opened by this fatty, oily mixture called surfactant. It's a mixture of protein and fats that lines the alveoli and prevents the tissues from sticking together and collapsing during exhalation. It reduces something called surface tension. Now, please don't be too involved with the structure of surfactant. You're not going to need to know that. When a person stops breathing altogether, whether it be through a drug overdose, a stroke, head trauma, or choking, they're said to be in respiratory arrest. The term arrest means to stop. If you get arrested on the street by the police officer, you've just been stopped. Cardiac arrest refers to when the heart stops. Usually when the heart stops, the breathing is stopped as well. Sometimes the breathing stops and the heart will still beat for a period of time, but if somebody doesn't take over and help that person's breathing, the heart will eventually stop as well. Now, if you guys have learned CPR at all, you've learned what to do in the event of respiratory arrest. You need to physically take over that person's breathing for them. The term bradypnea refers to abnormally slow breathing. Abnormally slow breathing. So in general, and don't get too fixed on the numbers, a healthy, relaxed adult should breathe anywhere between 12 to 20 times a minute. 20 is a little bit on the fast end, but it's still within the normal parameters. If a person is breathing only 4 or 6 times per minute, they're probably very sick. They might even be unconscious. And we refer to them as being bradypnic or having bradypnea. And body can't tolerate a breathing rate that's that slow for a prolonged period of time. We talked already about inspiration and expiration. The term hypoxemia refers to low level of oxygen in the blood. What's the whole purpose of the respiratory system? It's to bring air in, which is 21% oxygen, deliver those oxygen molecules through the respiratory tree, and ultimately dump them off in the bloodstream, where it can be carried to the heart and recirculated and sent to all the tissues in the body so they can metabolize properly. Oxygen itself is carried in a part of the blood called the red blood cell. Some of it's diffused in the plasma, but most of it is carried in red blood cells. If you have a low level of oxygen in the blood, you're said to be hypoxemia. And what are some of the signs and symptoms of hypoxia? Cyanosis, bluish skin color, initially seen in the extremities and the distal fingertips and toes. The appearance of shortness of breath, trying excessively hard to get that air in. Person may wind up having an elevated heart rate because if they have a low level of oxygen in the blood, they need to pump that blood faster to get the oxygen that they have to the tissue, specifically the brain cells. Because if they don't, the person may result in having unconsciousness. If anybody's ever known someone with asthma, they know that very, very common with asthma is this peculiar noise called wheezing. It's a high-pitched whistling sound, and it occurs because the bronchioles themselves become constricted and inflamed and swollen, and so air going through these narrow lumens creates a turbulent airflow, which results in that whistling sound. That's exactly how a toy whistle works. You blow into it, and it has a little device that narrows the passageway of air, causes resistance, and results in that high-pitched sound. So one of the mainstay treatments of a bad asthma attack is to, after the initial evaluation, is to prescribe certain type of medications called corticosteroids, like Solumedrol, methylprednisone. Prednisone is a very common one, by the way. And these drugs reduce swelling, they reduce inflammation, they reduce an exaggerated immune response, which can all contribute to certain type of respiratory diseases. There's a number of different ways of administering them. There's a number of different dosages and prescriptions. It really depends on what the provider deems as most appropriate. I already talked about some of the accessory muscles that are used when a person needs extra help breathing. So it just bears repeating that the normal muscles of respiration are the diaphragm and intercostals. When a person has a very difficult time inhaling, they'll use their sternocleidomastoids, their pectoralis, and their scalene muscles. If they have a very difficult time exhaling, they'll use their abdominal and they'll use their internal intercostal muscles as well. We talked about the two membranous layers in the chest cavity, the visceral pleura and the parietal pleura. The visceral pleura lines the lung, the parietal pleura lines the chest wall, and the two are sandwiched together with a little thin fluid separating the two to reduce surface tension and friction. Sometimes this fluid can become infected, and it can cause a condition called empyema, and that can be seen on an x-ray, and sometimes it becomes so bad that it can restrict a person's breathing. So in the hospital, they usually do a procedure called a thoracentesis, where they go in with a needle, they stick it into the chest cavity. It's a very delicate procedure, and they drain out that fluid, for one, to relieve pressure on the lung, and two, to examine the fluid in the lab to see what type of pathology we're dealing with. So bradypnea referred to excessive slow breathing. Hyperpnea refers to excessive rapid breathing, and you can see on that graph right there. As I said before, 12 to 20 is about your average. Anything over 20 to 24 is considered to be hyperpnic, and that can be a result of a lot of things: exercise, stress, fever, hypoxia, just to name a few. When a person comes into the office complaining of coughing and coughing and coughing, One of the things we want to ask about is it a dry cough or it is a wet cough? When we say wet cough, we're really talking about something that produces a lot of mucus. Most of the times, dry coughs occur from either asthma or an upper respiratory problem, whereas a real wet cough is something that's involved with the lungs itself. Now, contrary to popular belief, the color of the mucus being brought up with the cough has no relevance as to the etiology of the cough, whether it's viral or bacterial. It's a commonly held myth that if a person's coughing up green or yellowish phlegm, that it's got to be a bacterial infection. There's just absolute no truth in that whatsoever. So another term to be familiar with is apnea. Apnea is the absence of breathing. Sort of like respiratory arrest, except when a person is apneic, they're not breathing, or else they're not breathing temporarily. A very common term you may be familiar with is sleep apnea, where a person's sleep is disturbed because their breathing is momentarily interrupted for a number of different reasons, resulting in them being jolted awake or at least partially awake and resulting in poorly restful sleep. Pulmonologists typically refer to and study different types of lung volumes. And there are many different ways of measuring how air goes in and out of each lung. The only term I would really like you to be really familiar with is something called tidal volume. Tidal volume is the amount of air that goes in and out of the lung with a normal breathing cycle. One inspiration and one expiration. Now, when you talk about taking a full deep breath, then we refer to that as the inspiratory reserve volume. That's the tidal volume plus the amount of air that you can additionally inhale. Conversely, if you breathe out, you can actually force a lot of air out of your lungs beyond your normal rest. That's called your expiratory reserve volume. So if you imagine blowing out 100 birthday candles, and I'm getting there pretty soon, that would be your expiratory reserve volume. Now, no matter how much air you blow out of your lungs actively, you cannot release all of the air in your lungs. You're still always going to have a little bit of air in your lungs, and that's called the residual volume. But by and large, when you're breathing normally, breath in, breath out, the average adult moves about 500 cc's or milliliters of air, and that is called your tidal volume, and that's the term I'd like you to be familiar with, please. So now let's talk about some of the more common pathological conditions of the respiratory system. Starting out with one called whooping cough, or otherwise known as pertussis, which we saw a big decline over several decades due to childhood vaccinations. But now to some communities that have the anti-vaccination culture, we have been seeing a resurgence of this disease recently. And it involves, it's a bacterial infection. It can infect anybody, but it actually has a prevalence for small children. And it's characterized by severe bouts of intense coughing and then some rest in between. They call these paroxysms. The cough is so intense and so deep that when a child takes a breath in, it makes a whooping kind of noise, which is where it gets its name, whooping cough. And this can carry on for weeks. It's also characterized by low-grade fever, exhaustion, muscle wasting because they're just not eating, they're not breathing, they're not sleeping, they're not resting. And sometimes these coughing episodes can be so intense and cause a child to vomit. It's very little response to antibiotic treatment. The children are usually put on antibiotics to help protect the other household members as well. Anybody who's ever had an acute bronchitis Well, let's break it down. Acute means sudden. Bronch refers to the bronchioles, and the suffix itis always refers to inflammation. Bronchitis is an inflammation of the bronchioles, usually done as a result of a viral infection. Many people think bronchitis is actually worse than it really is. Bronchitis simply refers to a chest cold, where there's an excessive amount of mucus and inflammation, and the treatment is primarily supportive with rest, fluids, very old school I know. Very rarely do antibiotics help acute bronchitis because it's by and large a viral infection. The job of the medical practitioner, however, is to tweak out and try to determine what might be bronchitis and what might be an actual bacterial pneumonia. A bacterial pneumonia will show up on a chest x-ray, bronchitis will not. If you ever listen to the lung sounds of somebody with bronchitis, you may hear this rumbling and crackling in all the chest fields. Chronic obstructive pulmonary disease has now taken its role as the second biggest killer of adults in the United States, taking a backseat only to cardiovascular disease. Chronic obstructive pulmonary disease refers to what it says there, a chronic condition that has flare-ups, whereas a patient really has an obstructive problem, meaning they have problems getting the air out of their lungs. And sometimes they can exhaust so much energy getting the air out of their lungs that they become so tired that at the point they have problems getting air into their lungs. And there are two major categories of COPD. There's chronic bronchitis and there's emphysema. The big common denominator of both of these conditions is a history of long-term smoking. Chronic bronchitis is defined textbook-wise as a chronic productive cough for 3 months out of the year for at least 2 years in a row, where a person has expelled a lot of mucus. They've destroyed the ciliary lining of their bronchioles. The cilia are little hair-like projections that help carry dirt and debris out of the respiratory tree to be coughed up, spit out, or swallowed and destroyed. When we lose that lining, then the bronchioles have to produce extra amounts of mucus to trap these particles, but they have no way of carrying it out of the respiratory tree. So the only way to expel this mucus is by a real forceful cough over and over and over again. And then the second one is called emphysema. Emphysema occurs when those little bubbly type sacs called the alveoli become destroyed and dysfunctional, and they don't work anymore, and they don't allow for gas exchange. So a person has less surface area to bring oxygen into their lungs. We commonly refer to the difference in these terms colloquially as chronic bronchitis is referred to as the blue bloater because they tend to be edematous, overweight, they tend to retain a lot of fluid, and they tend to have a bluish skin color during their worst times due to hypoxia. Emphysema we refer to as the pink puffer. They're pink because due to that chronic lack of oxygen, they tend to develop a lot of extra red blood cells to try to take over the condition. They expend so much energy trying to breathe that most of their caloric intake goes into breathing, so they become very emaciated and frail. And as I said before, the common denominator for both of these conditions is a long-term history of tobacco use. Smokers are more likely to develop heart disease, lung cancer, and strokes. It's the number one preventable cause of all of these conditions, but tobacco can affect any body system. It can affect brain cells, it can affect the neurologic system, it can affect the circulatory system, it can affect the renal system. Passive or secondhand smoke can also cause lung cancer, strokes, low birth weight babies, and as we mentioned as well, heart disease. Third-hand smoke refers to all the particulates of exhaled smoke that falls on the floor, which can affect animals and children who wind up coming into contact with these toxic chemicals. Very common condition, very common in areas like the Bronx and Harlem, is asthma. Many people know of asthma, but they don't really know about asthma and what asthma does to you. Well, what is asthma? Asthma is what's called an acute on chronic condition. It means it's a condition that a person always has, but they can go through long periods of time without a flare-up, or they can have multiple episodes in a very short period of time. It involves two things. It involves constriction of the bronchioles, making air exchange more difficult, and it also involves inflammation of the bronchioles, which again makes it more difficult for those bronchioles to expand and makes it more difficult for air to pass through these bronchioles. And with the inflammation of the bronchioles also comes an excessive amount of mucus production. So when a person has an asthma attack and they're trying to breathe in, breathing in opens up the bronchial passages, making air exchange not so difficult. It's the exhalation process that's the problem, because when you have an already narrowed bronchiole through constriction and inflammation, constricting even more as you're collapsing the chest cavity, you're having a much, much more difficult time exhaling air than you would in other conditions. That usually contributes to that turbulent wheezing sound that we associate with asthma. It's important to note, though, that not all asthmatics wheeze, or not all people exhibit wheezing when they're having an asthma attack. Some asthma attacks are signified by just an excessive amount of nonstop coughing. If you have a patient who's having a real bad asthma attack and you can't hear anything in their lungs, that's actually a very ominous sign, because if they're not wheezing, then they're not moving air. So wheezing is not the worst thing in the world because they're still moving air. When the lungs shut down and no more air can move to make that noise, that's a very, very sick person. We initially treat this condition with medications to open up the bronchioles. These are bronchodilator medications. Very common one is called albuterol. It can be administered either via pump or a fine mist in a machine called a nebulizer. And then there's other treatments down the line for not only the acute attack, but for long-term maintenance as well, which we'll talk about later. Another condition called pulmonary edema occurs when fluid backs up into the alveoli of the lungs, making it very difficult for oxygen to be diffused from the airway into the bloodstream. A number of reasons why this can happen, but the most common reason is from an actual cardiac problem called congestive heart failure. The heart needs to pump a certain amount of times a minute with a certain amount of force. If the heart cannot pump out the blood that's coming back to it from the lungs adequately, it's like a boat that has a leak and can't be bailed out quick enough. Fluid will back up into the lungs, and ultimately the liquid part of the blood will seep in from the capillaries back into the alveoli, causing these levels of fluid, which can make it very difficult in itself for that person to breathe, and it can be life-threatening. There are other reasons this may happen as well. Kidney failure can cause it as well, and sometimes intrinsic lung disease called acute respiratory distress syndrome, which usually occurs in hospitalized patients who are very, very sick. We saw a lot of that with COVID in its initial stages. Pneumonia is simply an infection of a segment of the lung tissue itself. Not the bronchi, not the bronchiole, but actually the lung tissue. It can be viral or bacterial, even fungal in nature. And it used to be the #1 killer of adults in the United States, in the world, really. Now it's kind of worked its way down to number 6 because of the advent of antibiotic and medical therapy. Pneumonia can be it can be categorized in a number of different ways. Typical versus atypical pneumonia, which is kind of weird because atypical pneumonia is more common than typical pneumonia. Typical pneumonia involves things like strep pneumonia, and these are people who are really, really sick. They're toxic in appearing. Atypical pneumonia is more commonly referred to as walking pneumonia, and these are less serious, less pathological conditions, but still need to be treated. Another very serious kind of pneumonia is something called hospital-acquired pneumonia or nosocomial pneumonia. This is a type of pneumonia that occurs when a person is hospitalized for a prolonged period of time and infection control measures haven't been as adequate as they should be, and a person winds up getting pneumonia from organisms that are sitting around in the hospital. These are very difficult pneumonias to treat. A pulmonary embolism is one of the most frequently diagnosed conditions or frequently thought of conditions, and it's also the most frequently missed. And unfortunately, the type of medical practitioner that makes the most accurate diagnosis of pulmonary embolisms is the coroner, the pathologist, the person who's doing the autopsy. A pulmonary embolism is a blood clot that usually travels from the legs, not always, and lodges itself in the lungs, causing damage to the lungs, lack of oxygen to the lung tissue itself, and lack of ability of that area of the lung to exchange oxygen into the circulatory system. Why does it happen? Well, as I said before, the most common cause of a pulmonary embolism is a blood clot that usually travels from the legs up to the lungs. Why does a blood clot happen in the legs? Well, the blood clot in the legs is referred to as a deep venous thrombosis. And there are a couple of conditions that can cause that. One of which is prolonged immobility. The blood circulation in the lower extremities is not as good as it is in the upper parts of the body. So we need to move around. If the blood in the lower extremities is not moved around through frequent muscle movement and activity, it tends to stay pooled and stagnant. And this is what happened back in the old days when people were recovering from surgery. The typical recovery regimen would be bed rest for 2 weeks. But as they were resting in bed, the blood would be pooling in their legs and then clotting and clotting and clotting and clotting. You can sometimes have this in people who are traveling long distance for multiple hours in one place in an airplane seat. As that clot develops, ultimately it's going to break off and it's going to travel upstream and lodge itself in the lungs. Another condition that can cause this is trauma to the legs. Either through an accident, such as like a broken leg, a skiing accident, a sporting accident, repetitive trauma to the legs. If anybody's familiar with the sport of Thai boxing, Muay Thai, this is a martial arts sport where the practitioners batter each other's legs and other parts of the body with baseball bat type kicks. If anybody remembers Muhammad Ali, he had a condition like this when doing an exhibition match with a wrestler, where the wrestler just kept banging away at the back of Muhammad Ali's legs and he developed all these blood clots. That's another condition. Another reason why this can happen is if the person just has an inborn or an innate propensity to develop clots. There are certain disease conditions which makes a person more prone to developing blood clots. Cancer can make you more hypercoagulable. Pregnancy can make you more hypercoagulable. Cigarette smoking can make you more hypercoagulable. And if you have any of these conditions and complaining of shortness of breath, then a pulmonary embolism has to be considered. And pulmonary embolism cannot be diagnosed in an outpatient setting. It has to be sent to the emergency room. A pneumothorax is a collapse or a partial collapse of the lungs. It can happen from an outside trauma like a gunshot or a stab wound to the chest, where air has now become sucked into that airtight cavity, or sometimes it can happen spontaneously where a little piece of the lung called the bleb, a little weakened section of that lung pops and the air inside of the lung squeezes out, it escapes out, and then it becomes trapped in this area between both pleural membranes, the parietal pleura on the outside, the visceral pleura on the inside. So as the person takes each breath, a little bit of air leaks out and occupies this space. And every time air comes out and occupies this space, it compresses and collapses the lung. And sometimes it can be so serious that it can compress the other structures of the chest cavity, like the great blood vessels and the heart. It can be a very life-threatening condition. Treatment involves, in the emergency room, sticking a tube into the chest between the ribs, attaching it to a machine, and sucking out that air in the pleural cavity to reinflate the lung and giving it time to heal. Lung cancer still remains the #1 cancer killer of adults in the United States because by the time it's diagnosed, it's usually in its advanced stages. And of course, the #1 cause of lung cancer, you guessed it, cigarette smoking. Is it the only cause of lung cancer? No, some people have a genetic propensity to it. Sometimes lung cancers can be a result of toxic exposures over time. We've seen plenty of that with the World Trade Center rescuers. But the prognosis is usually pretty dire. It involves a combination of radiation therapy, chemotherapy, and sometimes even removal of a section of the lung itself. And that's why each lung is divided into multiple segments. So you can take out 1 or 2 segments of the lung and still live a relatively productive life if it's caught early enough. So it's important to understand the difference between respiratory distress and respiratory failure. If a person is having some trouble breathing, but they're at least breathing adequately when they just need a little medical intervention, versus when their respiratory system is shutting down, in which case they're pretty much circling the drain and dying. Well, how do you tell the difference, or how do you recognize respiratory failure or inadequate breathing? Well, first of all, they're probably going to have a very depressed mental state. When somebody is having an active asthma attack for pulmonary embolism, in the initial stages, they'll be very anxious, they'll be very irritable. But when they stop caring, they become depressed or they become lethargic. That's a red flag. If the rate of their breathing either becomes super fast or super slow, and we don't have to really tie into the numbers, you'll recognize it when you see it. That's another sign of inadequate breathing. A very irregular pattern of breathing, where maybe they're breathing slower and faster and slower and faster, or they're breathing and stop, and they're breathing and stop. That's another sign of respiratory failure. If you listen to the lung sounds and you can't hear anything at all, that's an issue as well. If their chest is just not expanding like it should, they're not getting enough depth or tidal volume in their breaths. And of course, if you look at their face and they're blue in the face, they're obviously very cyanotic. So let's talk a little bit about how we would assess someone with a respiratory complaint. Obviously, if you look at this gentleman in the picture, he does not look comfortable. He's sitting in what's called a tripod position. He's trying to align his airway for maximum air exchange. We don't know what's going on. We just know this is serious and that we need to jump on this fast and notify the provider fast that we got a very sick gentleman in room 6, even though he looks like he's in his living room here. Okay, so let's look at this gentleman, for example. So obviously, I can tell you right now, he probably has a history of emphysema. He's not sitting back in his chair very comfortable. He's perching his head forward. He may be a little anxious. He may be a little lethargic. You already see that he's on oxygen chronically. He's in that tripod position. From head to toe, you may notice some cyanosis in the lips and the mucous membranes. You may see him flaring his nostrils and pursing his lips. When pursing his lips, he's putting his lips together like he's blowing out a candle. and that's an attempt to retain as much oxygen on the way out as he can for better absorption. Look at the position of his collarbones, how they're positioned almost straight up to the ceiling. His shoulders are upright. He's got a very barrel-sized chest. He is pretty thin and emaciated. He's probably been using all of his metabolism just for the process of breathing. And these are just a few of the signs and symptoms you may notice. It's very difficult to appreciate all of them on a two-dimensional photo. That's why I very much encourage you to look at the videos in your training folder prior to next week's exam. So what are some of the treatments that we would give for somebody coming in with some acute respiratory distress? Well, one item would be to administer oxygen. There are a number of different ways that oxygen can be administered. A very common non-invasive way would be something called the nasal cannula, which involves two little prongs that go into the nose and wraps around the ears and is attached to an oxygen machine to give a little bit of supplemental oxygen to try to alleviate the symptoms. The doctor may encourage you to listen to the patient's breath sounds. The only way to really understand and appreciate different types of breath sounds is to have somebody listen to them who knows what they're doing, and then take you to the side and have you listen to them and practice over and over and over again. There is a video in your folder that goes over the different breath sounds like rales, wheezing, rhonchi, pleural friction rubs. Be familiar with the terms, but again, to really appreciate it, you got to get in there clinically. A non-rebreather mask, or sometimes called a partial rebreather mask, delivers a very high concentration of oxygen to somebody who's really hypoxic. Whereas the nasal cannula can give anywhere from about 20 to 40% oxygen, the non-rebreather will give close to 100 when set up properly. But this is for the person that's very sick. And how do you know who needs a nasal cannula and who needs a non-rebreather? Well, one tool available to you is something called a pulse oximeter, which I think you're already familiar with when we did vital signs. It measures the saturation of oxygen within the red blood cell itself. And depending on what text you read, anywhere from 94 to 95% and up is pretty good. Anything less than those numbers requires some intervention. Can also give you an idea of what their pulse rate is just by reading out a digital display. If you haven't done so already, please refer back to the video in this week's folder. A metered dose inhaler is a device that administers medication to help with conditions like asthma or COPD, and it can deliver either what's called rescue medication or maintenance medication. Rescue medication is meant to act right now and help that alleviate the symptoms of this attack that's going on immediately. Whereas maintenance medication usually involves things like corticosteroids. Is something that a patient takes every day on a fixed schedule to try to prevent future attacks from occurring. These devices can be a little difficult if you don't have good coordination. You have to kind of time it so that you spray it and inhale at the same time and hold it. They make these spacer devices that makes the process a little bit easier, especially useful in children when they're taking these medications on their own. A nebulizer is a machine that delivers medication, usually albuterol and some others, in a fine mist to help get a little bit of a deeper penetration of that medication deep into the lung tissues. The treatment usually lasts maybe anywhere from 5 to 15 minutes. There is a video that shows you how to set up a nebulizer. We'll try to do that in lab. But it's very well within the medical assistant's scope of practice. If the practitioner says, please give an albuterol treatment via nebulizer, you should know how to set that up. And these are just some other slides to go over. Positive pressure ventilations involves actually physically taking over that person's breathing, In the old days, we used to call it mouth-to-mouth resuscitation, but we don't really want to make skin contact with somebody we don't know. Maybe you do, but that's your own business. So when we breathe normally, what are we doing? We're breathing on something called negative pressure. We're expanding our chest and we're pulling oxygen in from the atmosphere. But if that mechanism isn't working, then we need some type of device to actually push oxygen into the lungs so it can be absorbed into the bloodstream. And there's a number of different devices that can be used to do that. One of the more common, which is called a bag valve mask resuscitator, that you might have learned if you've taken CPR class, or you will learn if you're taking CPR class. And once again, we'll try to cover in future labs when we have some spare time. Non-invasive positive pressure ventilation is commonly referred to as CPAP or BiPAP. And for the acute patient, these are usually employed in EMS and in the emergency room. And they just help give a little bit of extra boost to that person's breathing. Some people have their own non-invasive positive pressure ventilation machines at home, specifically people who suffer from obstructive sleep apnea. Giving that little extra push of air while they're sleeping, I don't know how anybody could sleep with that machine buzzing, helps alleviate those symptoms of not breathing and waking them up from their sleep. It is effective. It does help. I guess it just takes a lot of getting used to. So some offices will offer what's called pulmonary function tests, and this measures the way a patient is able to take in breaths and how they're able to expire within a certain amount of time, how much volume they can bring into their lungs, and how quickly that they can get air out of their lungs. And it's all plotted on a graph with a number of different types of numbers, which I don't require anybody to understand. Unless you're a respiratory therapist. If you're going to go into that field, that's a good field to go into, by the way. But we will go over how to administer these tests. And your job as the medical assistant is really just to kind of coach the patient through. It's like having them take the deepest breath of their lives and blowing out 100 birthday candles in one shot. They're going to want to quit, they're going to want to stop, and you want to really encourage them not to. And there's a video, again, let's go to the video, in your lesson folder to show how this works. Another video, how to set up a nebulizer machine. That's something you want to do. And also when you're administering a nebulizer medication, you want to make sure that patient is actually breathing in the medication. So it's important to tell them to make a good seal with their lips around the mouthpiece, to take deep, slow breaths to allow the medication to penetrate. A lot of it is coaching. And we've talked about the importance of coaching earlier in the semester. So as far as assisting with the examination, a practitioner really can't evaluate a patient with a respiratory problem if they're covered up in jackets and coats and sweatshirts. So it's really incumbent upon the medical assistant to set that patient up, at least have them partially disrobed, possibly put a gown on, assist the provider, provide privacy and support for the patient, perform the diagnostic test as ordered. If the provider wants to get a chest x-ray on the patient, make sure the patient is changed into the gown. If they're wearing a wire bra, they need to remove that. Be discreet, be professional. Sometimes it's important for the medical assistant to show a patient how to use their MDIs, meter dose inhalers, with the spacer devices. Provide them with clear instructions. Make sure they know where their medications are going. Make sure they understand the importance of their medications. Answer any questions that's within your scope of practice. Any question that the patient has that's not within your scope of practice, or it's just something you're not clear about, please refer right back to the provider before that patient is discharged. Okay, so let's just review some of the more salient points of today's talk. So, which are components of the respiratory system? Nasal cavity, trachea, lungs, or all of the above? Of course, that's all of the above. What is the anatomic location of the lungs and the trachea? Cranial cavity, spinal cavity, thoracic cavity, abdominal pelvic cavity? That would be the thoracic cavity. What is the function of the respiratory system? To maintain the acid-base balance in the body? To carry waste products away from the cells to be excreted in the urine? To exchange oxygen from the atmosphere for carbon dioxide waste? Or both A and C? And I think you got that. Both A and C are correct. Which test is a CLI waved test? Now, I don't believe I did cover this yet, but we'll cover it now. A VQ scan. A VQ scan stands for ventilation perfusion scan, which can detect pulmonary embolisms. An arterial blood gas, which is a needle that goes into the artery to be sent to the lab to determine oxygen status, acid-base status. A sputum cytology test, which involves a patient coughing up a deep glob of gook, of snot from their lungs, to be sent to the lab to evaluate for things like tuberculosis. Or a rapid strep test, which involves a little swab at the back of the tonsils to check for the possibility of strep throat. So yes, rapid strep test is a CLI-A wave test that can be performed in the office. What medication is considered for quick relief asthma? Fluticasone, montelukast, budesonide, albuterol? The answer is albuterol. Fluticasone and budesonide are both corticosteroids. Montelukast is what's called a leukotriene inhibitor. It inhibits some parts of the immune system. It's kind of like a third-line medication. Albuterol is used for rescue medication. It's a bronchodilator. We talked about surgical removal of an entire lung, which sometimes is indicated in severe lung cancer, and we would call that a pneumonectomy. A pneumonectomy. Pneumo meaning lung, ectomy, removal. A lobectomy would be partial removal of the lung. Remember, the right lung has 3 lobes, the left lung has 2. Which disease caused by a bacterial infection of the respiratory tract is also called whooping cough? And if you remember that term, that was called pertussis. Pertussis. Which are characteristics of an infant's respiratory system? The airway collapses as the neck is overextended, the trachea is shorter and softer, and the airway is narrow. I think you probably got the answer, all of the above. What is the maximum volume of air that can be forcefully and rapidly exhaled as possible after taking a full inhalation? I won't put that on the test, but that would be the forced volume capacity. What is true regarding oxygen delivery? A nasal cannula has a flow range between 1 and 6 liters per minute. The soft nasal cannula prongs must curve downward when placed in the nose. A mask has a flow range of 5 to 10 liters per minute. All the above are true. All the above are true.